This brief video will review how to perform an infant lumbar puncture and take you through the indications, necessary equipment, steps in the procedure, contraindications, and methods for troubleshooting. Lumbar puncture in infants is primarily used to help diagnose meningitis. The decision process of when to perform an infant lumbar puncture will not be covered in this video. The preferred supplies for an infant lumbar puncture include 1 or 2 22-gauge 1.5-inch spinal needles with stylets, a skin cleanser such as betadine or chlorhexidine, sterile drapes, 3 or 4 CSF collection tubes, sterile gloves, gauze sponges, and a Band-Aid. Before beginning, the provider should obtain informed consent and confirm the patient's identity. Resuscitation equipment, such as oxygen and a bag valve mask, should be available in the room in the event of cardiopulmonary compromise. A vital sign monitor may be used to monitor the patient during the procedure. The infant should be secured by the holder in either the lateral recumbent or sitting position. Instruct the holder to flex the infant by holding at the waist and shoulders. This helps widen the space between the spinous processes. The holder must be careful not to obstruct the infant's airway during the procedure by flexing the baby's neck. Palpate the superior iliac crests and imagine a line connecting the two sides. The gluteal cleft can help you to visualize the midline of the spine. At the center of this line is the L5 vertebrae, which can be used to help you identify the L4-L5 above or L5-S1 below interspaces. After washing your hands, don sterile gloves and clean the skin using 3 applications of betadine in widening concentric circles or chlorhexidine in a scrubbing motion for 30 seconds. The field should be covered with sterile drapes. Place the tubes on your sterile field in the upright position with their tops unscrewed. Proper analgesia is not only more humane, but literature supports that it may actually improve the success rates of the procedure. Topical anesthetics, such as lidocaine or prilocaine mixtures, can be applied 20 to 40 minutes before the procedure. A sugar-containing solution administered with a pacifier can help relieve pain and anxiety through an opioid-like effect in young infants. A small gauge needle and syringe can be inserted into the skin to raise a small wheel at the intended site. Then the deeper subcutaneous tissue can be anesthetized by directing the needle inward 2 millimeters at a time while drawing back to be sure not to aspirate blood and gradually injecting lidocaine. The bony landmarks will not be obscured if the lidocaine is massaged into the skin and 60 seconds are provided for absorption. Now that the insertion site has been identified and anesthetized, palpate the landmarks once more. It may help to hold your thumb in position over the spinous process below or above the space you will be inserting the needle. Hold the needle in your dominant hand between the thumb and index and middle fingers. Insert the needle with the stylet in place, perpendicular to the skin, with the bevel facing to the flank or side of the patient. By keeping the bevel parallel to the longitudinal dural fibers, it allows the needle to separate these fibers instead of lacerating them. Insert the needle into the intervertebral space in the midline of the back at an angle of approximately 15 to 45 degrees, aiming towards the patient's umbilicus. Achieving and maintaining the proper patient position and alignment of the spine and needle can be a challenging aspect. If the alignment is not maintained, you may run the risk of hitting bone or an epidural venous plexus. Once the needle passes the skin, take a moment to assess whether your angle is correct, as your landmarks may have shifted if the infant moved during needle insertion. After passing the skin and subcutaneous tissues, the stylet is removed. This technique, called early stylet removal, has shown to improve success rates for infant lumbar punctures. The needle should be advanced slowly in increments to a depth of roughly 1.5 to 2 centimeters, while closely visualizing the needle hub for fluid. As the needle passes the ligamentum flavum and enters the subarachnoid space, you may feel a popping sensation or a sudden decrease in resistance. However, you may not feel this popping sensation. Once cerebrospinal fluid is flowing, you may remove your grip from the needle, as it should stay in place. Approximately 1 milliliter should be collected into each of the tubes, keeping track of the order in which they are collected. Try to avoid touching the end of the needle with the collection tube, as this may move the distal tip of the needle out of the CSF space. After adequate fluid is collected in each tube, replace the stylet and remove the needle in one fluid motion. Apply pressure to the site with sterile gauze until blood is no longer oozing from the site. Clean off the skin using water and apply a bandage to the insertion site. All sharps used during the procedures should be properly discarded into a sharps container. We will now describe common problems and possible solutions. If the needle is advanced and bony resistance is encountered, withdraw the needle into the subcutaneous tissue without exiting the skin and redirect the needle in a different plane. Reevaluate the positioning of the patient, the spinal alignment, and your angles of insertion to find the correct plane. If flow starts and stops or is coming slowly, try rotating the hub of the needle 90 degrees in a clockwise direction. This will help to displace any fibers that may be obstructing the opening and point the bevel towards the patient's head, which will allow for greater surface area to collect CSF. Unfortunately, sometimes the fluid in the needle is bloody. It is important to distinguish between pure blood and CSF that is mixed with blood. Watching the fluid to see if it clears up is one way to confirm that you are indeed getting cerebrospinal fluid. Even though this fluid may be bloody, it can still be sent for analysis. Another way to tell if bloody fluid contains CSF is to look for a halo effect by allowing a drop to fall on a piece of sterile gauze. Here you see blood remains in the center while a concentric clear ring forms around it representing CSF. If the blood does not clear, reinsert the stylet, remove the needle, and you or another provider should retry with a new needle. An infant that is moving or is not properly positioned is a frequently encountered challenge. Enlisting extra help to help you hold the infant, or the use of sedation or analgesia, can help prevent movement and ensure a safe and effective lumbar puncture procedure. Never aspirate fluid using a syringe, because this negative pressure may precipitate hemorrhage. It is dangerous to perform a procedure when circumstances are not ideal. The airway, breathing, and circulation of a patient should always be assessed to assure there is no cardiopulmonary compromise prior to performing a lumbar puncture. Unstable patients should not undergo a lumbar puncture until they have been properly stabilized, and antibiotics should not be delayed in this case. Other contraindications include signs or symptoms of increased intracranial pressure or focal neurological symptoms. In cases like this, intracranial imaging should be considered. The spinal needle should not be inserted into skin with an overlying infection or rash. A neurosurgeon should always be consulted prior to considering a lumbar puncture in any patient with a ventricular peritoneal shunt, a tethered cord, spina bifida, or a physical exam that's suspicious of another spinal dysraphism. There is an increased risk of spinal hematoma and bleeding in patients with low platelets or other bleeding disorders.